Yeah, everybody. I have a special guest on our show today. Her name is Dr. Tracy DeSplinter. So, welcome to the Healthy Joints, Healthy Lifestyle Show. For those who don't know me, I'm Dr. Arinola Dada, and I'm your host. Today, we have an amazing host. I'm so excited for the beginning of the year to start on this like big high. So, her name is Dr. Tracy DeSplinter. We're going to out what she does and how her journey onto this point. So she is a board certified OBGYN obesity medicine certified in the Menopause Society with over 25 years of experience providing care for women. So Dr. DeSplinter, thank you so much for coming to the show. Excited to have a little bit about what's your background and a little bit so that our audience knows who the phenomenal Dr. DeSplinter is and why we're so excited to have her.
Hi, Dr. Dada. Thank you so much for having me. I am Dr. Tracy DeSplinter. I'm an OBGYN. Board certified with, just like you said, 25 years of experience. More recently, I've become certified by the Menopause Society, and I have achieved certification in obesity medicine. So I serve women in midlife with very comprehensive care so that they can feel better now and continue to feel better and age better over the next decades.
Fantastic. So, and you have also you started DP a direct DPC practice. Tell us a little bit about that.
Yes, I'm making a career change. I've been employed as a general OBGYN doctor for my entire career. And starting next month, I will have my own practice. It's a direct care practice for midlife women. Yes, so I serve all women needing gynecology care, but specifically focus my practice on the midlife, which is when a lot of women are suffering with perimenopause symptoms and transitioning into menopause. It's a time where I think we have an opportunity to help people feel so much better now, and then also change the trajectory of their health as they age.
One of the things that we were talking a little bit about was about why you wanted to do DPC and what you were dissatisfied with, kind of the usual, what's the way you've been kind of over the years, the way the relationship with the patient has been interfered with, should we say? And
Yes.
why and the real reason and the reason why you wanted to do the direct patient care.
Yes, very important question. So, the way that when we work for health insurance companies, essentially they are kind of our boss and they're governing us, and the way that they reimburse hospital systems and employers, it forces us to do 10 to 15-minute visits. So that means all day long, every day, I have a new patient or an existing patient on my schedule every 15 minutes. That's not 15 minutes with the doctor and the patient together. That's 15 minutes for the patient to arrive, be checked in, maybe go to the restroom, have her vitals checked, get situated in the room. Then for me to come in and visit with her, listen to her, hear her complaints, her concerns, counsel her, examine her. It's about 5 to 7 minutes face to face time for all of that. So it's really doesn't allow for true relationship based care. These 5 minute snippets are absolutely not enough time for comprehensive, thorough care. And I think it leaves the patients dissatisfied and struggling, and it leaves the doctor dissatisfied and struggling as well.
Yeah, yeah. And that makes so much sense, especially, as we, what and in the areas that you're treating. I mean, there's a lot that you kind of need to kind of have build that relationship, so that the patient can have that trust, like and feel so that they can really kind of share what they're dealing with.
Absolutely. Gynecology in general, women are very vulnerable. And then in the midlife, when women are struggling with lack of sleep, hot flashes, night sweats, joint pains, all of the things that happen in perimenopause, and through the menopause transition, it's even more so. You can't address all of the current and future health needs of a woman in 5 to 7 minutes. So
Yeah.
I really look forward to the direct care model where I can spend more like an hour with each patient to really build that relationship so that she feels comfortable and that she gets adequate time to express herself and to be heard and to be counseled and for us to come to decisions together with regard to her care.
Well, I have no doubt that that practice is going to be successful because you already have an amazing reputation. So I look forward to, hearing more about the practice and how women are undergoing this life-changing experience just by having the benefits of being in your care. So congratulations. Looking forward to hearing more about it.
Thank you so much.
Okay. So one of the things that we had kind of talked about a little bit was kind of sharing, why do you do what you do? What inspires you?
So, what inspires me is the relationships that I've built with women. So, throughout my career, delivering babies, of course, kind of lured me into the field. That is always fun and always rewarding, but gets to be pretty exhausting. The lifestyle is pretty tough and also kind of hard on our health. But then what I learned is that my practice aged with me. So women that I saw years ago, 20 years ago, who were struggling with fertility problems, then eventually conceiving, seeing them through their pregnancies, through their deliveries, then catching up with them each year or more often sometimes to hear about what's happening with their kids and with their careers and with their families. I realized that what I love the most is the relationships.
Yes. Yes. Yeah. Yeah. So you're evolving with your patients. As your patients are evolving, your practice is also evolving to continue to care for them as the years go by.
Yes, yes. And I find that to be the most rewarding aspect of OBGYN, just that long-term continuity of care with strengthening relationships with each patient.
Yeah. Yeah. I feel the same in rheumatology. We usually have our patients. I've had patients that we've been together for the last 20 years, ups and downs, but always moving forward and always moving towards progress. So I love that about your practice. Excellent. So, so we're going to kind of go into what we're talking about today, which is the menopause and muscle and joint health and kind of what every woman should know.
Yes, I think this is kind of one of the intersections between your field and mine, rheumatology and gynecology.
Yeah.
And it is really under publicized, under known um, aspect of perimenopause and menopause is the changes that occur in the musculoskeletal system. So, bone loss, I think most people are aware of, which leads to osteopenia, osteoporosis, the risk of fragility fractures, which can have a terrible impact on quality of life and actually on length of life. But
Yeah.
in addition to the bone loss, there's also big changes that happen in the joints, the connective tissues like the tendons and ligaments. There's significant loss of lean muscle mass, which has impact not only on strength and function, but also on the way the metabolic health plays out. So, lots of important changes happen in the perimenopause and after menopause in the musculoskeletal system.
Yeah. Yeah. No, so a lot of and so when women are having I would say the most common thing that I have found with women in that perimenopausal to early menopause is rotator cuff issues.
Oh, absolutely. So frozen shoulder is a big
Yes.
one. And sometimes it can be less extreme than absolute frozen shoulder, but it can
Mhm.
progress to that quickly. So the connective tissues like the ligaments and the joints, excuse me, the ligaments and the tendons that are around our joints and involved in the joint function, they have estrogen receptors. And when estrogen plummets after menopause, it has dramatic effects on these tissues, and it can limit mobility. It can cause pain, inflammation, lots of changes that are important to know, and I think not well not well known.
Yeah. So it's interesting. I think before the literature can, I mean, right now menopause is a hot button. Thank God, you know. Um, so in so I've been doing rheumatology practice as a rheumatologist for 20 plus years. And with the rotator cuff issue, I just found that a lot of perimenopausal, postmenopausal women had this. And it wasn't until recently that I really could find some data that would support it. But otherwise, is there a way a clinician can determine if the pain is perimenopausal versus just rotator cuff tendinopathy, or do you just kind of look at the age of the patient? Is there something else that would kind of help you raise your antenna to say, hey, are we looking at something more necessarily more perimenopausal, and would you treat it any differently?
Oh, yes, I think that it's important to take in the patient as a whole. And if she is in an age range, late 30s to, through the 40s, where perimenopausal symptoms are likely, then definitely it's a consideration. Then you have to kind of speak with her and listen to her and hear, is she having other issues? Is her sleep interrupted? Is she having hot flashes? Has there been a change in her menstrual cycle pattern? Oftentimes, I think joint pain and the musculoskeletal issues happens first and isn't recognized by the patient and often the clinician as part of perimenopause. Then after some other menopause changes start to happen, or excuse me, perimenopausal changes start to happen, like changes in the menstrual period and hot flashes that are more characteristically recognized, then women kind of look back in hindsight and they go, I've been having joint pain for 4 or 5 years. I've been waking up at night, not necessarily having a night sweat, but just interrupted sleep for several years. So when they look back, they recognize that these symptoms were happening and they just didn't associate it with perimenopausal changes. So I think to answer your question, you would need to consider the woman as a whole and what's going on with her in general. And yes, age is a big part of it. If she's in that age range, you should raise your antenna.
Raise your antenna. Can we talk a little bit about hormone replacement therapy?
Oh, of course, that's one of my favorite topics.
So, when do you use it? How do you use it? What's the ideal candidate? When do you run some blood tests with at that before you go ahead and do it? Tell us a little bit about, what the selection criteria would be.
So I look at it more as exclusion criteria because really almost every patient, almost every woman experiencing perimenopause is a candidate for hormone replacement. We actually call it menopause hormone therapy now. But unless there are absolute contraindications, everybody should consider it. It should be something that's part of the discussion with every woman. Not every woman chooses to accept or take hormone replacement or menopause hormone therapy, but every woman deserves the discussion, regardless of any previous medical history, family medical history. It should always be discussed and individualized. In general, hormone levels are not typically necessary, especially in perimenopause, because a hormone level in perimenopause is going to give you a snapshot of that very moment. And it may look totally normal. That doesn't exclude perimenopause. It may look like menopause, but that doesn't actually diagnose menopause. So the hormone levels in perimenopause tend to be wildly fluctuating. Sometimes the estradiol level may be super high, and sometimes it may be in the basement. So the levels usually don't tell us that. There are some exceptions.
Yeah.
There are some times that it's important to check, and there are some women who just need that piece of information for their own intellectual curiosity and to help with their decision making. But in general, you don't necessarily need the hormone levels.
Interesting. Cool. Okay. And have you found out kind of hormone replacement, menopause replacement therapy has made a difference? Does it prevent? Does it make a difference in kind of the incidence of a lot of these musculoskeletal symptoms that we're talking about?
It absolutely does. So some of the musculoskeletal system changes that we may not have touched on would be the progression of osteoarthritis, um, and menopause hormone therapy, replacing the estrogen that is causing these symptoms or that can cause it if left untreated, ameliorates a lot of the symptoms. It can prevent the development of osteoporosis. So about 20% of women after age 50 have osteoporosis, and about 30% of women older than 65 have it. We know that during the years after menopause, 50% of women will suffer a fracture related to loss of bone mineral density. So this is huge. It can actually be fatal in women over 65 to break a hip.
Oh,
Um,
definitely. Yeah.
so
It's
one
life
of the
altering.
yes, yes, and life threatening, about 30 to 50% mortality rate in the first year after a hip fracture
Yeah.
if you are 65 or older. So I think menopause hormone therapy is absolutely pivotal just in that one regard that it can help to prevent the development of osteoporosis. It can also help with joint pains and muscle aches and sleep, and getting good quality adequate sleep can help with a lot of these symptoms as well.
Definitely. And just going on a different tangent with the sleep disturbance, a lot of my patients, when they have fibromyalgia, general pain, we go back to sleep and to figure out, are you getting the right phase? Are you getting adequate time in the right phases of sleep? What's REM sleep looking like? And that's another reason this postmenopausal, perimenopausal period, when people have some sleep disturbance, that actually can affect your mental well-being and also create or exacerbate generalized body pain in conditions like fibromyalgia.
Absolutely. Sleep is huge. It's important in all phases of our life, of course, but during the perimenopause and after menopause, interrupted sleep can cause problems, just like you said, with mental health and well being, but also with lots of different aspects of physical health. During menopause and perimenopause, a lot of women develop sleep apnea.
Mm,
So we think of stereotypically sleep apnea being an old man with a big neck, heavy body, but actually it's under recognized in women
yeah,
and can be life threatening and life altering as well. So
yeah.
getting a handle on good quality sleep and assessing if sleep doesn't improve adequately with menopause hormone therapy, I have a really low threshold for getting sleep study, which is a formal test to make sure that there are not sleep abnormalities like restless leg syndrome and obstructive sleep apnea.
Yeah. Yeah. When I tell my patients about the fact that I want them to get a sleep study, you see their eyes get really wide because they're like the getting treated with the CPAP does not look sexy. And and I'm always encouraging them that, they are exactly what you said. There are many causes of poor sleep hygiene. Let's figure out what it is, and then we'll make an informed decision. Because maybe it's restless leg, right? Maybe there's some other reason why we have the sleep disturbance, but don't be concerned yet. Let's figure out what it is, and then we'll make an informed decision. Because there are many ways to treat sleep apnea, not just a sexy mask.
Yes, absolutely. There are more treatment options than that, and
Yeah,
there are more sleep disorders than that.
and that,
And
exactly.
sometimes you may find that there is not a sleep disorder, and you can move on with menopause hormone therapy and sleep hygiene and all the other, less intense treatment options than the CPAP.
So as we were talking about women and we talked about bone density, what steps do you recommend that women can take to protect their bones and muscles and reduce their risk of fractures and just kind of get that healthy life maintained?
Absolutely. Lifestyle measures are super important. So, menopause hormone therapy, if they're a candidate, they should definitely consider that. Um, moving, walking, exercise, whatever they can do as far as weight bearing exercise, um, lifting weights, hopefully under the direction of an expert to get started so that they reduce the risk of injury. But lifting heavy weights, and heavy is relative to each person, that can help. Optimizing nutrition. So making sure that the woman is getting plenty of lean protein and then lots of different vegetables, fiber, micronutrients that are found in vegetables and fruits, um, whole grains. So optimizing nutrition is a big one.
Okay. Fantastic. So how many usually with weights, do you have a recommendations? How do they start? Because I think people are overwhelmed if they haven't been to the gym, or maybe they don't even like the gym. I think people who like the gym, you don't like the gym, you don't like the gym. Um, I think a middle-aged woman, a midlife woman who has not really been to the gym may be a little intimidated. Um,
Sure.
and so
Yes.
how do they start? Do you have any kind of practical recommendations for how to start?
So I think something as simple, if she's doing nothing, something as simple as just walking around the block, if she lives in an area where that's an option. Just starting slow, not making huge changes all at once, and just finding a way to get out and move. Just being outside actually can help with mental well-being and mental health. And then in turn, it helps with physical health because it's kind of motivating to get out and do it again. Another good thing to do to get started is to find a community, whether that's one friend who's also motivated for the same reasons, or a group class that's made up of other middle-aged women that can be motivating and can make it actually fun.
Yeah, yeah. I mean, you could go for walks with your friend and not even realize you've gone for a walk because you just did so much chit chatting, and then you could be
Yes,
like, "Wow, we already did 2 miles. We already did 3 miles, right?" So,
yes,
yeah,
yes,
and it's always also, I think, agree with you that when you're doing it with a friend, it doesn't really feel. It feels more like a fun thing to do rather than it's another tedious task.
yes. It can be something to look forward to, something to enjoy, and
Yeah,
increase your sense of community.
yeah.
And I think that that's one good way to get started.
Yeah, for sure. So, would you be able to share a story of a patient who had an amazing outcome after the benefit of being in your care?
So thinking about this from a musculoskeletal standpoint, I think of a patient who came in having sleep disturbance and hot flashes. She was only 42, and she felt that she had been told actually that she was too young for perimenopause, and that she shouldn't consider treatment for that. She did not need contraception at that moment, so we decided to try some menopause hormone therapy. I gave her a low dose patch of estrogen and a progesterone pill to take at bedtime. She came back 3 months later, and when I walked into the room, she started crying. And I was like, oh no, what's going on? No, she was so grateful, and she felt so much better. She had just a tremendous response to this simple treatment, and it moved her to the point that she came in not because she needed any adjustment, but because she wanted to tell me how much better she was, and how grateful she was.
Wow, that's amazing. That is amazing. So, we haven't talked about where do you practice? How could people find you? Where are you in this United States?
So I'm in the suburbs of Houston, Texas, and I serve the women of Texas currently. I may be getting another state license or two eventually, but yes. So I have an in-person options coming soon, as well as telemedicine options for women in Texas.
Okay. Well, I think we women need all the help we can get. So we're looking forward to you starting this DPC practice, getting your licenses in other states. Yeah, because I think at this point, I think women are waking up to their needs and looking forward to getting some assistance in our journey. I'm going to put me too there because we're all kind of in this together.
Yes, we are.
Yes, we
To
are.
to find me, my website is tracydesplintermd.com. I'm
Okay.
also on social media, Facebook and Instagram, using my real name.
Okay, so the Facebook is Tracy, TraciDe Splinter.
Yes.
And then your Instagram is at Tracy Splinter, MD. And then we're gonna have this at the bottom of the video when it plays on YouTube. Well, Dr. DeSplinter, thank you so very. I forgot to ask you my favorite question. If you had any superpowers, what would
Oh,
it be? Oh, why?
oh, that's a hard one. I think it would be communication. So if I could
Mm,
speak to every woman in her late 30s
mm,
to give her a heads up of some of the things that are to come, and to
mm,
give her the knowledge that this is
mm,
treatable, and it
mm,
does not have to be a time of suffering,
mm,
and that speaking up and seeking treatment
mm,
can not only help how she feels in her 40s and 50s, but it can actually change the trajectory to put
mm.
her on a path of healthier aging and longer health span and well-being.
Oh. Thank you so very much. I think we are so lucky as women to have you kind of in this area of menopause, perimenopausal prevention, making sure that, over time we're actually living healthier lives and having better quality of life. So I really, really appreciate you coming. First visit of the year. Appreciate you coming on the show and looking forward to hopefully interviewing you again once your practice starts because you've got to tell us what's happening.
Well, thank you so much for having me. I truly appreciate it. You're helping me develop this superpower, and I would love to come and join you again.
Okay, fantastic. Well, so everybody, if you like this video, or you know anyone who's in the Texas area and in Houston, looking for help with menopause, perimenopausal symptoms, women's health, make sure you find Dr. Tracy DeSplinter. Like this video, share it, and we'll see you next time on the Healthy Joints, Healthy Lifestyle. Thank you so much, Dr. DeSplinter.
Thank you.